My name is Lucy Mackay. I'm the CEO of the charity Medics for Rare Diseases. And you may be wondering why I'm here holding a breakout session about newborn screening, because it's not really my zone, but it's something I'm very interested in. And so therefore I harassed Jo and she let me do this. The reason I'm interested in it is I used to be a doctor and I have some experience of doing parts of the newborn screening program, mostly the one part of which is the examination and often the blood spot test. But also my background is my brother had a rare genetic condition and I have an idea, I won't say I know personally, but I have an idea of the benefits that can be had from screening. And then the other side to it is, it's talked about a lot, newborn screening, like the words newborn screening, it comes up a lot. But having been a doctor and had that training, and having had that personal side, sometimes I'm in conversations and I'm not sure that everyone knows exactly, is on the same level of knowledge with what newborn screening is, and the newborn screening program, not to be confused with any research projects. So here today, I've got a lovely panel, and I would just like to say that Sophie Thomas from the NPS Society was meant to be here, but sadly she can't, and we're really gutted that we can't have her, but she has sent us her thoughts, and she has worked closely with the people on the panel. So I have Dr. David Ellerman, and who is a clinical advisor for the Newborn Screening Committee and the Blood Spot Task Group as well. And then let me open, sorry, otherwise I'm going to ruin everyone's titles. Giles Lomax, CEO of Spinal Muscular Atrophy, who's also the father of twins with SMA2. And then Nick Mead, the celebrity, no offence to the other two, from Genetic Alliance UK, Director of Policy, who I'm sure you'll be familiar with. And so today, like I said, we're going to be covering the basics. What is newborn screening? What's the difference between screening and diagnosis? How are things chosen? And what are we doing? That kind of thing. So hopefully that's what you're here for. So first of all, to start us off, we're going to have David talking because he's going to tell us those basic questions. What is newborn screening?
Thank you. Thank you for all coming. I know my place now in the shadows. I'm going to very briefly, well, that's a good start. The slides actually work. That's a good omen. So what I'm going to talk is very, very briefly about newborn screening. Now, in this country, and I just looked it up, if the UK National Screening Committee makes a recommendation, the government pledges to follow that. Now, that's a second section. There's a section above it, which is your rights to have it in legislation. So the pledge is just a little bit lower down than that. But having said that, every time the screening committee has recommended we should screen for something, that has been followed and implemented. It covers the whole of the UK, so that's Wales, England, Scotland, and Northern Ireland. Makes recommendations, and as I say, usually the ministers follow that, though there are different timings as to when things may be implemented. And the basic premise is that we want to ensure that there is more good done than harm at a reasonable cost. And all of those are important. It's a balance, and one of the things that is very important to remember, if we take a condition like SMA, for example, which has an incidence about 1 in 10,000, we will screen, say, 10,000 babies. So 10,000 babies will be subjected to the screening process, and there will be one baby who has SMA. And there may be benefit to the one baby who has SMA, but we want to make sure there's not disbenefit to a large number of the other people being involved. We can talk in more detail about how there might be disbenefit, but we need to put both sides of the equation in. The decisions are based on evidence reviews on the whole, and people can recommend something is screened for. There will be a call beginning middle of next year, which will be open, I think, for 3 or 4 months, and anybody can put in for that. And then it will be considered. If there seems to be prima facie case to look further, because there is evidence in the literature, would be followed up with a detailed review. And then more and more what we're looking to do is using models, because you can imagine if you're looking for a rare disease, if you wait for real life experience and get statistical significance, etc., you may be waiting a hell of a long time. So if we can make a model that says, what if we screen for this? We don't know certain things. Does it matter that we don't know those? Because we can say there is a small or a big chance of their harm or a benefit or a cost, but we can put this into the model, and the model may say, doesn't matter how much that is, it's still beneficial. So modelling is one way of doing it. Another way, and these are not mutually exclusive, is we could actually try doing a screening programme. And we are running one at the moment for a condition to do with your immune system. And we're going to hopefully get enough information to put into a model to see if its cost effectiveness comes out positive. And we'll also be looking at the experience of the people who go through the programme. Now, what we currently screen for are a number of things. It's not just the blood spot. So we screen babies to see if their hearing is badly affected. We can't pick up mild problems with hearing, and that happens before a baby would go home. Babies are also routinely examined. They have a physical examination, and we're looking there for problems with their heart, with their eyes, with their hips, and if they're boys, with their testes specifically. And then there's the newborn blood spot programme, and this is where a heel prick sample is taken at 5 days of age, goes off to a laboratory, and a number of tests are done for some very specific conditions that the NSC has looked at and says, yep, these fulfil the criteria, more benefit than harm at a reasonable cost. If you ask, I won't ask this audience because I will get a different response, probably. But if I were to ask a general audience, did they remember? A high proportion of them wouldn't have remembered that it had been done, let alone what tests were done on that sample that was taken, what conditions were looked for. And this is going to be a bigger problem as we screen for more conditions. How do you properly inform people so that they know what they're consenting for and remember that? So the conditions we do currently screen for, these two have been long set way before the National Screening Committee was set up, but would fulfil the National Screening Committee's criteria. Then there are sickle cell disorders, which you've heard about, cystic fibrosis, which is quite a complex thing to screen for, and genetics is not necessarily the answer. And then 5 more metabolic conditions. So we currently screen for 9 conditions. We're doing a trial of one, we're planning a trial of another, and a third has been approved, and we're working out the process to implement that. And that's as much as I was going to say.
Thank you so much, David. I'm just going to hopefully remove this mic, everyone. There we go. I'm just going to pass that to Nick, and then I'll come to you, Giles, if that's okay.
Yeah, sure.
So I really need my one. You can hear me on the mic? Yeah. So thank you for that introduction, David, and that examination that David just mentioned. That's what I used to do a lot of. Any mums might remember a doctor picking up your baby and then dropping it for the Moro reflex. That was me. But Nick, I was just wondering, because this is something you've been sort of in talks about for a long time, and as a sort of that umbrella organisation with GA, why is newborn screening so relevant to rare disease?
Thanks, Lucy, and thanks for having me. I think it's relevant for rare disease support organisations because they see the success of the service that David's described. So this is a very high uptake with very strong public acceptance, and it's delivered a tremendous amount for the 9 conditions that we currently screen for. So and essentially identification of a rare condition at birth where there's a treatment available can lead to much better outcomes than when we diagnose through other routes. That's the kind of simple thing that our community are looking at. I think also our members look across at organisations like Cystic Fibrosis Trust, and they see other stuff that's really valuable. So we know exactly how many people in the country have cystic fibrosis. We don't really know that for most other rare conditions. And they've managed to organise themselves to collect data about people living with cystic fibrosis, which has been really powerful to develop the treatments that are now available for that condition. That's not currently a reason to do newborn screening and isn't a way to get that approved in the UK, but that is a benefit that I think we as a broad community look at and think is really, really effective. And then the whole idea of diagnosis is crucially important in rare conditions. So it's number one in the priority of the UK Rare Diseases Framework for a reason, because it's a defining portion of most people with a rare condition's life, and can be an extremely large part of that life. And so therefore, I suppose at face value, newborn screening looks like a really obvious solution to that. It's definitely much more complicated than that. But I met a guy on Tuesday who had a 36-year diagnostic odyssey, despite presenting at age 6 months with the major symptom of his condition in a paediatric hospital. So, you know, there are some real value for newborn screening. And I think for every single rare condition, there would be a different perspective.
Yeah, and I like what you say there, because so screening is done in lots of conditions. You know, there's screening for, you may be aware of breast cancer screening or fecal occult blood screening for bowel cancer. So screening is as a principle a way to take if I'm wrong, make sure you tell, but take a population where you know people might be at risk and find triage for those who are potentially at risk, and then do a pathway as a pathway, so then you'd go on to diagnosis. So we do it in other things, and there's specific criteria for it. But it's really interesting that in rare disease, data is such a problem because you're already rare, but then also that's only the data that we have of the people we know about. So being able to systematically collect data in rare would be amazing, can you imagine? But obviously that's not on the criteria for why you would screen for a rare condition. So Giles, as a father of twins with SMA, and you work with SMA, are you able to bring that perspective of what early diagnosis could mean for families?
Yeah, thanks so much for having us as well. It's a great point. I think just picking up on some of Nick's points there as well, is that, you know, having that access to not just the data if we were to go through newborn screening for spinal muscular atrophy, it opens up so many different opportunities, not just by providing early access to treatment, but also given that other parts of how to support somebody who is living with SMA, so wider care provisions, physiotherapy, occupational therapy, respiratory, all of that kind of side of things. And we do know that the treatment is hugely effective, but in some cases it's not all the way through. I think if I look at some of my own examples from being a father of twins, I'll try and park that to one side, but representing so many different families. So we only have 1,500 people, we believe, living with SMA within the UK. And that's only because they've come to us at various touch points. There will be lots of other people potentially out there who have adult onset or later onset that are still part of that SMA community, but aren't kind of through our database at the moment in time. I think if we look back at the effectiveness of newborn screening as well, with a particular focus on that early intervention through the treatment options that we do have available, we know that there are unbelievable amounts of examples now that just highlights that if you do get drugs within the first few weeks of life through that genetical testing, the outcomes are so positive. And in many cases, children will not have any atrophy whatsoever. They will be able to grow up and have relatively normal lives, not sometimes completely normal life, but they will have a very, very near to normal life. And I think that argument alone is really, really, really powerful to potentially some of the other negative effects that could be considered within adding SMA into the programme.
Yeah, And we'll get onto the balance because everything is a risk balance ratio, right? And when we're in this area and people are well versed on rare disease, something can seem so obviously potentially feels like the right thing to do. But what we're always missing is what we need to take into account is what's the other responsibilities when we're making those decisions, and we'll get onto that. I think that something you're saying there about also the fact that you are getting that at birth, that you said it's such a high percentage uptake of this test. And so a really good way to demonstrate this is say both sickle cell disease and cystic fibrosis have been screened for at birth for a really long time, and that's done systematically. And so we have good data on both of those. But if you then look at innovations in cystic fibrosis versus sickle cell disease, where there's potentially social and health inequity at play because they're from different groups of populations, ethnicity-wise, you then see that they might start up at the same point with the testing, but then you see how social and health inequity starts playing a role. Imagine if we then didn't use newborn screening to detect sickle cell disease. I wonder if we'd think it's actually not that common in the UK. So I think that's always something to sort of think about. But obviously part of where we are, particularly why has this conversation started coming up so much these days? And I think you've touched on it there. It's treatment. As treatments become more and more available, so the condition that killed my brother has had a treatment for a long time and isn't screened for. So this isn't a new phenomenon, but we then have this added problem here, and I was just wanting to sort of come back to that bit about treatment and how you see going forward, maybe starting with Giles, when you've got this new part to the ethical problem.
It's a really great point, and particularly with the personal example that you share there, it does create inequalities. It does create bigger issues that we look at. So if we're on behalf of SMA fighting with the cause to try and get SMA through, it can then create pulling away from the overall that everybody within the rare disease space should be putting pressure within the kind of systemic decision making, the systemic core issue of actually in 25 years' time, when we look back, have we got the right system now to make sure that all rare diseases have the opportunity to be screened, or a lot more opportunity for the rare diseases to be screened? Yes, the ones on the board and potentially others within the three that David mentioned are great pioneers, and they lay the road down and they help other rare diseases to be able to forge that path. But when you go back to that kind of real high-level ambition, it's actually how do we work collectively, and obviously particularly with GA and things, actually what do we need to do at that level to make sure that we've got everybody within that space all working in the same way, in the same direction, to be able to actually drive treatment change, drive social change, drive other support services change around that as well.
And so Sophie wanted to highlight some figures of a study they did with a condition called MLD, where 95% of the families who were surveyed supported newborn screening for MLD because there's a treatment. But again, you can imagine why. And I want to go to David now, because what about that other side, so the public who are potentially not really getting informed consent? As we said, I don't know who's had a baby. Did you know what conditions were on that card when they had their 5-day heel prick test? So we've got to think about when you're adding conditions about that consent piece, and this is the general public, and how we address that bit.
Can I cogitate on that and just add something? When the NSC does a review of something, there are lots of things they would consider, and often top of the list are, is there an actionable, is this an actionable condition, however you define it, and there are different definitions, but the other is how accurate the test is, because these tests aren't 100%, and particularly if you take something like cystic fibrosis, we unfortunately label some children with an acronym that I'm not going to spell out, but basically means we don't know what their prognosis is. A lot of them, the majority in fact, would never have a problem, but we have told the parents they may, and they're followed up in outpatients. And there is a temptation to treat them because they might have a problem. So we are labeling people inaccurately. Now, the business about consent is a very, very big and real problem because what we aim to get is informed consent. Now, you can define that as much information as someone wants to feel happy about giving their consent. So I might, being a pedant, want to know the minutiae, whereas most parents turn around and say to the midwife, well, what would you do? We've touched upon whole genome sequencing, which is being piloted. Currently, the number of conditions proposed is 200 odd, with 500 odd genes, with tens of thousands, if not hundreds of thousands of variants. Can you imagine a consent saying, do you consent to? You know, half an hour later you get to the bottom of the list. That's not going to be appropriate. So we're going to have to, or the community in general is going to have to think about what they mean by informed consent. And it's probably going to end up as being a tiered thing. You know, do you consent to your baby's whole genome being sequenced and us passing on to you the results for these conditions? No, for 200 odd conditions. Yes, no. If dubious, then there's a website that you can look up much more on it for the parents who want to ask it. And I think that's the only way we can go. I don't think providing everybody with a list of 200 odd conditions is practical or even fair on people.
And I think David, that it's not just in this, I think consent in general, you know, a woman in labour being given a consent form, I mean, there's already problems with how we that anyway, and I think I've looked at the...
Well, the newborn screening, we would not do that because they get the information during pregnancy and then afterwards. It's carefully thought out.
In general, there's been conversations about taking consent anyway and how we can digitalise it and make sure it's put into multiple languages and different formats. So it's kind of exciting. But
don't miss out the people who aren't digitally competent.
But yeah, definitely. And so we do have a question that I wanted to build into this because there was a group of medical students who I'm a fan of, medical students, they are our future doctors, and they went into this study in Edinburgh thinking about newborn screening and finding out what people thought about it and what should happen next for newborn screening. And so Asher has provided a video, but due to the other tech issues today, I'm not going to attempt to play it, although we did try. What she said was she went into this thinking, well, hang on, come on, we should, you know, she came into it saying, kind of, we really need to start, this seems obvious to screen for more diseases, and the more she learnt about it, the more complex she found it. And what their study did was talking to professionals and people within organisations, NHS, whoever the professional is, but people with lots of knowledge about it. And then they took the medical student opinion, which they took as a slightly informed general public, i.e. they're meant to know about it, but they don't know about it, and then looked at it and saw what they felt. And she said she actually came out of it thinking there needs to be a change, but what is that, and how do we engage the public more in this? Because this is ultimately, we might understand why we're talking about this, but it's going to affect everybody who's interested in having a child or a grandchild or a loved one who's going to be born at some point. What do you think, Giles, about bringing the more general public in? And also, let's remember, most rare diseases will never be screened for, ever. So, because, you know, they might not have a genetic cause, we might not know the genetic cause, it might not be that. So, you know, are we a proxy general public?
Yeah, I think on that point, I think the education is really important, like really, really important. The whole newborn screening and its ambitions and what it does and all that side of things is great. I think it's actually bringing it down a level sometimes to make it more bite-sized, more digestible for somebody to actually understand why. So if there are 615,000 births in the year and pretty much everybody gets the heel prick test, roughly under 1%, I think, don't. But then if we bring down some of the stories, so for example, from a really specific SMA point of view, I have families that are living within SMA that have older siblings. So a 4-year-old potentially who are living with SMA, who are full-time wheelchair users, have multiple care issues, respiratory, physio, X, Y, and Z. Their sibling has been tested at birth because of their sibling's nature's positive example, have been given interventions and then live really normal lives. Other examples as well, one of my colleagues has a 7-year-old son who has type 1 SMA, so one of the most severe types. He's 7, he has 24-hour nursing care. It costs 460 grand a year for his care package, which could have not cost everybody that amount of money if there was newborn screening. So I think when you are educating things, if you actually bring it down a level, it becomes a lot more bite-sizable, it becomes more relatable, it becomes more personable, and I think people then kind of get behind and understand how that could be rolled out across a number of different rare diseases.
I think patient stories are always one part of the puzzle. It has to be there. Nick, any thoughts on?
It's really interesting because I think we are the majority of this panel is speaking from the rare condition perspective, which is a minority of the public. One suspects that potentially the public's attitude towards knowing information about conditions that they might not know a lot about has changed since March 2020, and our attitude towards also our understanding of maybe not wanting to know whether you have a condition you can do nothing about might have grown as well. There's these research studies that we've referenced a little bit are going to generate an enormous amount of evidence. So it's really good that they're being really ambitious and having long lists, because at the moment they're research studies. So the more we find out as we do them, the more evidence we'll have. But we're heading towards a point where we might need to go to the public and say, what about changing our historical approach to how we balance the benefits of newborn screening and using all techniques against the harms of newborn screening? And both of those are quite complicated. Some people might not think some of the benefits are in fact benefits. Some people might not think the harms are particularly severe, but others would disagree. And once we've got all of that evidence, I would be in favour of a really in-depth discussion, something like a citizens' jury, something where we can go into depth as to the history of research on the harms of newborn screening and all of the new evidence we generated about the benefits of newborn screening, and trust a group of our population, including some people with rare conditions, but also including people from all walks of life, people from all backgrounds, and actually talk about what we could achieve with newborn screening. I do have some stuff about, big blue sky thinking on newborn screening, but I don't want to hog the limelight.
Go to David, and then we'll come back to the blue sky.
Over to you, David.
I can't remember exactly when it started. Probably about 2 years ago, may even be 2.5, 3 years ago. So it may have fallen during the worst bit of COVID. But prior to all the work on the whole genome sequencing, there was a public dialogue that took place. And this was general members of the population with a definite attempt to get people who were of childbearing age, if you like, people also from ethnic minorities and a spread across the UK, to seek their general views, not on specific screening things. And on the whole, in general, they were in favour. They weren't very keen on uncertainty, so they didn't want to be told something that could mean a problem, might not mean a problem. They were very clear on the whole that they only wanted to be told about conditions where there's something you could do, and that intervention had to be widely available. It wasn't something that some people could access. That would not be on at all. So there's a general agreement, like in lots of things in life, but when you come to the detail, it becomes a little more difficult. And I would agree with you, you need the views of the general public and the people who have that lived experience one way or another. Both are valuable. Then the issue is sort of how much weighting do you give to each? And there is no formula for that can guide you.
I would just say on that I think that this is, for me, the start of my blue sky thinking, and I was saying to you, Giles, is part of this is history. So a lot of screening is about history. So we currently still screen for Down syndrome and other trisomies during pregnancy. We screen for hearing at birth, but if you go and talk to the deaf community, there is quite a large group of people who don't back hearing screening at birth. And I do wonder whether part of the blue sky thinking is, having a sort of a line in the sand. Is we know it's not perfect, okay, and we know it needs to change, but we need to change it slowly in an informed manner and go back to basic principles. Have you got a similar blue sky to me, or am I raining on your blue sky, Nick?
I think you're talking more about how quickly we turn the sky blue. I have just a few kind of ideas in terms of what could be achieved with newborn screening, and I think it's interesting to have them on the table, because these are coming from the rare condition community, which we all know here has a tremendous set of unmet health needs, and the kind of spirit of a lot of our advocacy is to leave no stone unturned. So maybe we should get all of the options out there and then discuss what could be done, and whether maybe why, to help us understand why we're not just screening for every single rare disease at birth, which, by the way, no one's advocating for. So at the moment, it's clear that we screen for conditions where there's a treatment. So dietary, and we're heading towards gene therapy treatments and bone marrow transplantation treatments. Those are the kind of conditions that we are likely to be screening for in the UK. The study that David mentioned has a kind of more of an intervention-based definition of treatment, and some of the key examples that really kind of focus my mind on these are children with babies born with osteogenesis imperfecta, which is a brittle bone condition, will be found using this study, and that's because you can tell their parents early in their life how to handle these children, and that child will have fewer fractures. So that's a different kind of philosophy around what treatment is. That's more intervention-based. And then there's a different research study which uses the term actionability, and that kind of question, what condition should go on an actionability, again, research study list, had a lot of ideas, and some of them were difficult to diagnose conditions. If there's a condition with a long diagnostic odyssey, maybe it's better if we screen for it at birth. There are learning disabilities that are really hard to spot, where if children are diagnosed with it earlier, they can get educational support much earlier, and their educational outcomes are much better. There are risks, though, to doing these things as well. You shouldn't change a long diagnostic odyssey into a long search for symptoms and a phenotype, and you shouldn't label a child with something that might not actually come forward. Pharmacogenomics is another thing, sensitivity to medicine. Should we be looking for that? That's, by the way, very popular with the public. The long diagnostic odyssey is very popular in the rare disease community, according to the Eurodis Rare Barometer, but also popular in the population, the general population, following a French study on this that surveyed the French population. Other ideas are conditions that might need a lot of monitoring, that might crop up, so cancer risk conditions, reproductive choice. Should we screen just so that families are aware that their first child has got a condition, and to make them aware that they have the opportunity to consider reproductive choice, to make a choice about their future children if they choose to have them? Should we be screening so that we can do clinical trials with people that don't have symptoms yet? These are all on the on the table. None of that screening's happening yet. And some of the research studies that are happening now are trying to understand whether any of that would be valuable. And as I say, once we get a sense of that, we then need to put that to the population.
I think also when it's not just the pressure on David and the three of you around newborn screening this decision, I know that we don't have much time left, and I do want to just get one last soundbite from each of you. But I like this symbolic empty chair. This symbolic empty chair could have someone from NICE in it, it could have someone from a pharma company in it, because also part of this is before there wasn't treatment for a condition, and if our screening hangs on there being a treatment, and then companies are forging ahead and we're investing a lot of money into the development of treatment just for people and families to be put in this rather excruciating position, then I think there has to be some responsibility here as well. And that's just sort of these, we can't take a patient and cut them up. We can't take a family and cut them up and have siblings who did get treatment and siblings who didn't get treatment. If we're talking about inequity of care, as a sibling of someone who died of a rare condition and knowing what it did to my family, that's something I'm very passionate about. So I like that symbolic empty chair there. But I'm going to come back. So if everyone, maybe we'll start with you, Giles. We don't want to get told off. So if you've got one thing to say to the audience about newborn screening, and maybe it's discussion or what you're thinking now.
If anything comes out for SMA, sign it. Get behind it. It has to happen. And it has to happen as soon as possible.
Also, hashtag let's work together.
That wasn't signed by it, I'm sorry.
A good quick change could be that we try to avoid the situation we've got with SMA now and do some horizon scanning. So when there's a gene therapy in clinical trial looking very promising, perhaps the UK NSC could be asked to have a look in advance so that we might have newborn screening much closer to the launch of medicines in the future.
I think that's a very fair comment. Some horizon scanning and I suppose some what-ifs. So at the moment we don't know, but we can plug in when it comes along and have a better turnaround time. We will have a better turnaround time in the future because the numbers of staff dedicated to this is going up quite significantly. The other thing that hopefully will make a difference, and I will not embarrass Nick by asking him to say yay or nay to it, is that there was very deliberately a task group set up to see how we could speed up things through the process, what things we could put in place that would improve matters, and Nick is part of that, and I chair it for my sins.
Well, we didn't take questions partly for a very specific reason of we were trying to keep this as an introductory session, but I'm sure all of our speakers and panellists would be willing to speak about specifics later. I really, really hope that you've learned something from this panel, that it's been useful, that it's meant even if newborn screening doesn't feel completely relevant to you right now, you understand that all of our voices are important. You can either be the general public or you can be the person who has all the knowledge, but everyone is really important in this. And I just want to say a huge thank you to the panel for coming together and being just brilliant at this. Thank you.